Welcome to Chapter 37 of NUR 203, Impact of Cognitive and Sensory Impairment of the Child and Family. Intellectual disabilities, defined by the American Association of Intellectual and Developmental Disabilities in Children, consist of three components, all of which we'll talk about on consecutive slides. It's used synonymously with intellectual disability, cognitive impairment. Diagnosis is made after a period of suspicion by the family or health professionals. In some instances, it can be made at birth, because children who are born with hydrocephaly and spina bifida and things like that, sometimes they automatically know that they're going to have some cognitive impairment. Functional strengths and weaknesses, age younger than 18 years of age at the time of diagnosis, and intellectual functioning are the three things used to diagnose this. Diagnosed at birth in some syndromes like Downs and trisomy 18, all the trisomies will have some cognitive impairment. But it can take up to age 2 before it's discovered in some children, just because they don't meet the milestones that we expect them to meet. CBUX 31.1 for early signs suggestive of cognitive impairment. So intellectual functioning would be a sub-average intellectual functioning of an IQ of 70 to 75 or below. Functional strengths and weaknesses, impairment in 2 of the 10 adaptive skills, which is on the next slide, and younger than age 18 at the time of diagnosis. So your functional impairments, adaptive skills include communication, home living, community use, leisure, health and safety, self-care, social skills, academics, work, and self-direction. Diagnosis and classification. Results of standardized tests are used in making a diagnosis of cognitive impairment. Diagnosis of mildly impaired characterizes 85% of the population with CI. These people are considered educable. That means they can be educated up to a certain point. Diagnosis of moderately impaired characterizes 10% of the population with CI, and these people can be trainable to take care of themselves with certain ADLs, but may not be educatable enough to hold down a job. See page 1024 for a list of things that can cause cognitive impairment that has to do with possibly genetic factors, biochemical, infectious, familial, means it runs in the family, social, environmental, and organic. Early intervention, or EIP program, is a systematic program of therapy, exercises, and activities designed to address developmental delays in children with disabilities to help them achieve their full potentials. So we need to educate the child and family about what early intervention programs are and teach the child self-care skills. Promote the child's optimal development, encourage play and exercise, provide means of communication, and establish discipline. These children have the same needs for play and exercise as a normal child would. Of course, this must be adapted to their cognitive and physical abilities. Verbal skills will probably be delayed more than physical skills. Speech requires both receptive and expressive skills. Nonverbal communication may be appropriate for some of these children. Some can learn to use sign language very well as opposed to speech. Limit-setting measures still need to be in place and appropriate for their mental age. Behavior modification, especially reinforcement of the desired behavior, and sometimes timeout, would be used just like with other children in the family. A push panel allows a child with cognitive impairment to turn on and off a computer in this picture. A manual switch allows a child with cognitive impairment to play with a battery-operated toy. and she seems real happy about that. A favorite toy provides stimulation for a young child. Nursing care of children with impaired cognitive function. Opportunities should be made available to these children at an early age. As soon as the parents are able, they should enroll the child in preschool environment for cognitive impaired children. Encourage socialization, provide information on sexuality as they get older. Help the families adjust to future care, and care for the child during hospitalization. Assist in measures to prevent cognitive impairment. A child with cognitive and physical impairment can activate electronic and communication equipment by moving a device near their head. Down syndrome is the most common chromosome abnormality. 1 per 691 to 1,000 live births. The cause is unknown, probably multiple causes, and it occurs in every population of all races. Non-familial trisomy 21, there's an extra chromosome 21 in 95% of the cases. Translocation of chromosomes 15 are either 21 or 22 in 3 to 4% of cases. Mosaicism is a mixture of abnormal and normal cells in 1 to 2% of cases. Maternal age has always been thought to and proven to be a risk factor for Down syndrome. So if you're age 35, your risk is 1 per 350 births. As your age increases, you can see that by age 40, the risk would be 1 per 100 births that you would have a Down syndrome baby. See page 1029, box 37.2 for your clinical manifestations of Down syndrome. Very important that you know these clinical manifestations. About 15% of Down's children will have what's called atlantoaxal instability. Almost all are symptomatic. See page 1030 to be familiar with this, because you will see this on HESI. And at the bottom of this slide, it gives you a good explanation of what atlantoaxal, oh my goodness, instability is. A young child with Down syndrome in this picture is holding a doll that has Down syndrome. How cute and innovative is that? So there are available therapies for Down syndrome children: surgery to correct congenital anomalies. A lot of them are born with cardiac problems. Evaluation of hearing and sight, periodic testing of the thyroid function. The prognosis depends on the severity of Down syndrome they have. Care management, supporting child's family at the time of diagnosis, preventing of physical problems, and assist in prenatal diagnosis and genetic counseling. Then we have Fragile X syndrome. It's the second most common genetic cause of cognitive impairment after Down syndrome. 1 in 3,600 boys and 1 per 4,000 to 6,000 girls, caused by abnormal gene on the lower end of the long arm of the X chromosome. Fragile X chromosome, clinical manifestations: they have large head circumference, a long face with a prominent jaw, large protruding ears, and large testes post-pubertal. Manifestations variable in the female carriers of the gene. See page 1031, box 37.3 for the clinical manifestations of Fragile X syndrome. Classical behaviors feature mild to severe cognitive impairment, delayed speech and language, hyperactivity, hypersensitivity to taste, sounds, and touch, autistic-like behavior, and aggressive behaviors. It can be treated with Tegretol or Prozac for the behavioral control. Stimulants for hyperactivity, similar to management of attention deficit hyperactivity disorder, referral to early intervention program, and the prognosis is a normal lifespan expectancy. Some say that Abraham Lincoln had the Fragile X syndrome, but I don't know that they could diagnose that back then. Care management would be genetic counseling. Hearing impairment definition and classification. 1 to 6 per 1,000 healthy full-term infants has a hearing impairment. 2 to 4 per 100 premature infants. Slight to moderately severe residual hearing with the use of an aid. Severe to profound hearing loss cannot progress. They cannot process linguistic information. So if you talk to them, you're going to get that blank stare because it's just kind of bouncing off. They don't understand what it is you're saying. Hearing impairment etiology, see page 1032. They may have an anatomic malformation. They may have a family history. They may have low birth weight. They may be on ototoxic drugs. They may have had massive O2 administration because they were on a ventilator for a long time. They may have had chronic ear infections, perinatal asphyxia, perinatal infections, or if they have CP. Hearing impairment pathophysiology or pathology and conductive hearing loss that's usually affecting the middle ear. Sensorineural hearing loss is damage to the inner ear auditory nerve. And mixed conductive sensorineural loss is interference with transmission of sound. Central auditory interception can be organic or functional. Symptoms are, for severity, they do a decibel type of hearing test where the unit of loudness bounces off the eardrum. It's measured at varying frequencies. The hearing threshold, critical listening, speech range, and it can affect their speech if they cannot hear well. So many conductive hearing loss in children depends on the cause and the type of hearing impairment. Many of these can respond well to medical and surgical treatment. When conductive hearing loss is permanent, it can sometimes be improved by a hearing aid to amplify sound. Sensorineural hearing loss is much less satisfactory. Cochlear implants may be needed to help improve with hearing. On-the-body hearing aids are convenient for young children, such as this one with severe bilateral hearing loss. Note the eye patching for strabismus. Strabismus is crossed eyes, so they're trying to make the one eye weaker, the weak eye covered and the other eye stronger with the patching one eye at a time. So lack of startle reflex might be an indication to you that your baby can't hear. Absence of reaction to auditory stimuli. Absence of well-formed syllables by age 11 months. The baby is still not talking. They're just making noise. General indifference to sound and lack of response to the spoken word. You walk in and you say something to the baby and they totally ignore you, like they're just dissing you, but when in fact they can't hear you. So profound deafness, likely to be diagnosed in infancy. If not detected in infancy, identified upon early, like preschool or entry into school. I hate to think that you were so out of touch with your child that you missed all this before they got into school. Abnormalities in speech development and learning disabilities. Hearing impairment, they can be taught to lip read, to be cued to speech. They can do sign language, speech language therapy. There are additional aids out there to help these children, and socialization helps a great deal. And support of the child and family is very important. Reassess understanding of instructions given when we're addressing the child with a hearing problem. Supplement with visual and tactile media. Provide communication devices like a picture board with common words, and assistance of the child life specialist. Additional aids, anything we can use to get our point across to the child. Preventive measures, treatment and management of recurrent otitis media. Genetic testing would be very important. Avoidance of ototoxic drugs includes antibiotics like gentamicin, streptomycin, tobramycin, loop diuretics like furosemide, and platinum-based chemotherapy such as cisplatin, carboplatin, and vincristine. Testing to rule out syphilis, rubella, or blood incompatibility, and avoidance of exposure to noise pollution. Visual impairments are a common problem during childhood. In the United States, prevalence of blindness or serious visual impairment is 30 to 64 per 100,000. 5 to 10% of all preschoolers have a visual impairment. It can be identified through a vision screening program. Definitions and classifications would include partially sighted school vision, acuity is 20 to 70, 220 to 200. Education, usually in the public school systems. Legally blind is acuity of 20, 200 or poorer. Legal and medical terminology. For legally blind children, you have to get a diagnosis for that. The etiology, prenatal or postnatal infections. Retinopathy of prematurity means that the retina detached because they were premature or because they were on the ventilator for a very long time and exposed to a lot of oxygen concentration. Could be from trauma, postnatal infections, sickle cell disease, Tay-Sachs disease, and one that you need to remember because you may see it on HESI or boards. Juvenile rheumatoid arthritis. With arthritis, it would not necessarily pop into your head that the child would need an eye exam because this is in the joints. But JRA children need to have annual eye examinations, so do not forget that. Types of visual impairment, you've got your refraction or bending of light rays through the lens of the eye. Myopia is nearsightedness. Hyperopia is farsightedness. Strabismus may or may not be refractive, and that's crossed eyes. And amblyopia is a lazy eye, just one of them. It just kind of droops and doesn't stay where it's supposed to. See page 1037 to 1038, box 37.5 for types of visual impairment. Trauma, common cause of blindness in children. Injuries to the eyeballs or the adnexa. Penetrating sharp instruments, propulsive objects, blunt objects, motor vehicle accidents. Non-penetrating lacerations, blows to the eyes or head, and burns. Treatment is aimed at preventing further damage. Please see page 1038, the emergency treatment box about eye injuries. Infections. The most common one we hear about is conjunctivitis, also known as pink eye. It's an inflammation of or infection of the transparent membrane, the conjunctiva, that lines your eyelid and covers the white part of your eyeball. When small blood vessels in the conjunctiva become inflamed, they're more visible. This is what causes the whites of your eyes to appear reddish or pink. This can be treated with ophthalmic antibiotics, systemic antibiotics in some cases. Use caution with steroids. It may exacerbate the viral infection, and remember that this is very contagious. Use good hand washing techniques. If you only have pink eye in one eye, make sure you do no cross-contamination when you're medicating your eye. Nursing assessment for visual impairment. Identify children who are, by virtue of their history, at risk. Observe for behaviors that indicate a vision loss, like constant blinking of the eyes or rubbing their eyes a lot. Screen all children for visual acuity. Nursing alert, suspect visual impairment in a child of any age whose pupils do not react to light. Promote parent-child attachment. Promote child's optimal development. Development and independence as much as we can possibly get them. Play and socialization is still important. Education can be done through Braille and audiobooks and learning materials. Provide a safe environment for the visually impaired child. Provide reassurance during all treatments. Orient the child to their surroundings. Encourage independence, and treatment team members should be consistent. Prenatal care, prevention of prematurity, rubella immunizations for all children, safety counseling to prevent eye injuries, and periodic screening for all children. Hearing visual impairment, profound effects on development. Motor milestones usually achieved, other development often delayed. Look up finger spelling, and also maybe look on YouTube for video about finger spelling. Would be a better explanation than I can just give you verbally. But Helen Keller learned how to finger spell in the palm of the hand of her teacher. And I can't remember the teacher's name now, but Helen Keller learned how to finger spell with her teacher. Developing future goals for the child is important. Communication impairment, autism spectrum disorder. Neurodevelopmental disorders, etiology is unknown. Clinical manifestations and diagnostic evaluation. Deficits in social interactions is a big one. They don't like to be around other people. Communication, they don't communicate well with other people. And they may have behaviors from just ignoring you to acting out. The prognosis can be improved and overcome through behavioral modification and a truckload of patience. Care management, interprofessional care, and lots of family support. Peculiar and bizarre characteristics, primarily in specific areas like socialization, communication, behavior, difficulty with eye and body contact. They seldom like to make eye contact, and they don't like to be hugged. Language delay, diagnosis often delayed until age 2 or 3 years of age. Several severely disabling condition. In some cases, there's no cure for autism. Some improvement with language skills. Numerous therapies. You need to recognize it early, attempt behavior modification, provide a structured routine, and decrease unacceptable behavior through all of these efforts. If this child is in a 2-parent household, both the parents need to be on the same page with how they react to this child. Autism often becomes a family disease. Frequently, parents express guilt and shame, stress importance of family counseling. Autism Society of America is a good source for information. Clients should be managed at home or in long-term placement facilities. If they're a danger to themselves or others, of course, it would be dangerous to keep them in the home around other children. So that's something you might have to consider eventually. Your question says, the nurse is discussing sexuality with the parents of an adolescent girl with moderate cognitive impairment. What should the nurse consider when dealing with this issue? The correct answer for this question is C. Adolescents with moderate cognitive impairment may be easily persuaded and lack judgment. A well-defined concrete code of conduct with specific instructions for handling certain situations should be laid out for the adolescent. Permanent contraception by sterilization presents moral and ethical issues and may have psychological effect on the adolescents. It may be prohibited in some states, but obviously there are some states who do allow this. The adolescent needs to have practical sexual information regarding physical development and contraception. Cognitively impaired individuals may desire to marry and have families. The adolescent needs to be protected from individuals who may make intimate advances and take advantage of these children. So the correct answer is C, and this concludes this chapter.